Good morning, and thank you for joining us for the Health Policy Institute of Ohio's online seminar, The Path Forward, What Comes Next for Health Policy. My name is Amy Rowley-McGee, and I'm the president of HPIO. With Congress failing to repeal or replace the Affordable Care Act this summer, the ACA remains the law of the land for the foreseeable future. With that in mind, what comes next? What are the biggest challenges to improving access and affordability of health insurance coverage within the law, and what are possible solutions? Today's webinar is the second in our three-part seminar series designed to provide timely and relevant snapshots of decision-making throughout 2017. Today we're joined by Robert Laszewski to provide insight on where federal health policy stands right now. Mr. Laszewski is the president of Health Policy and Strategy Associates and the author of Healthcare Policy and Marketplace Review, a blog. He is an influential national speaker on the healthcare market, frequently contributing to and commenting on national news. His writing has appeared in Forbes, Kaiser Health News, and other national publications. In addition, his consulting clients include health insurance companies, casualty insurance companies, HMOs, Blue Cross organizations, hospitals, pharmaceutical companies, and physician groups. You may have attended a forum that HPIO hosted a few years ago where we had Bob here in person, and we thought he would be a perfect addition to our seminar series this year as we explore where we're heading. Now I'm just going to cover some housekeeping details. The slides used during today's presentation, as well as a password-protected recording of the seminar, will soon be available on our website, hpio.net. During the presentation, please feel free to type questions in the question box at any time. There will be time for Bob to answer questions at the end of the presentation, and we'll get to as many of the questions as we can. If you don't see the question box, your control panel may be minimized. To bring it back, click the orange arrow in the corner of your screen. And now, here's Bob.
Well, good morning. It's good to be with all of you, and I appreciate the opportunity to speak with you again. I'm going to give you an update this morning. I can't give you a conclusion to the healthcare debate of 2017, or maybe it's going to be the healthcare debate of 2017, 18, 19, and 20, but we can talk about where we are right now because obviously not a lot's been accomplished. You know, the Republicans have failed to repeal and place Obamacare, and obviously they didn't distinguish themselves very well in this whole debate. It's not over. It's possible we'll still have some progress. We'll talk about that. I think it's important as we look back at the debate of the past few months to understand what Republicans were trying to do and understand where Democrats were drawing some lines in the sand, because that will tell us a lot about where we're ultimately going to end up. Now, before I get into those details, I think it's really important to look at the 50,000-foot picture, the long-term federal budget challenge that's largely driven by healthcare entitlements. Because as we get into the weeds about how Obamacare, the Affordable Care Act, should change, particularly with respect to the exchanges or Medicaid, it's important to understand this backdrop because it really is critically important to the whole debate. This is a picture of the long-term budget outlook in the United States. And the dotted line is about, the up and down dotted line is about where we are today. And we look into future years and what's happening to spending. As you can see, our long-term debt grows substantially. The solid black line that moves from left to right is projected revenue, and anything above that is going to be deficit, and as you can see, the deficit continues to grow. And you can see what happens to the rest of the budget. Net interest on the debt grows because we've got lots of debt. Interest rates are likely to rise. Other spending at the very bottom shrinks as a percentage of overall federal spending. And this includes everything but healthcare entitlements, Social Security, and net interest on the debt. So the Pentagon and all of the other federal budgets are in that bottom piece. And as you can see, it shrinks. So spending on defense and so forth shrinks as a percentage of the economy over future years. And this is the track we're on autopilot on right now. Without any further cuts, without any changes to Medicaid or Social Security, this is where we're going. And as you can see, Social Security is a big part of the problem, but not anywhere near as large as the ballooning health care entitlement. We really have to get that under control. Now, as we look at what we have to do, here's a chart from the Congressional Budget Office just this March of 2017. And what it shows us is the size of the policy changes we need to make in order to bring the federal budget in line. And it's a daunting set of numbers, especially if we look at the top of this chart. In order to have the budget deficit at 40% of GDP, which is the 50-year average, where we've been for 50 years, by 2047, 40 years from now, each year we'd have to either increase federal revenues by 17% or cut spending by 15% between now, each year between now and 2047. Just ponder that for a second, and what a deep hole we're in here. If we were to just keep debt at its current level, 77% of GDP, we're way above the long-term average, we'd have to increase revenues by 10% or cut spending by 9%. The bottom of the slide shows you how much in taxes that would mean for the average household. But again, just ponder that for a moment, how deep the hole we are in. So when Republicans say that we've got to bring the entitlements under control, they're absolutely right. We have to. There's no doubt about that. And that's part of what they've been focused on here. But whether it's the Democrats or the Republicans, we have quite a daunting task ahead of us in trying to get everything under control. So I think it's important to have this as a backdrop before we get into the details of what Republicans or Democrats might do. So let's look at the Affordable Care Act, popularly known as Obamacare, in its current state. And let's look first at the insurance exchanges. There are two big parts to the new Affordable Care Act entitlements: the creation of the insurance exchanges, the reform of the individual health insurance market, subsidies for people above 100% of the federal poverty level, and then, of course, the expansion of Medicaid up to 138% of the federal poverty level in the states that have taken that expansion. So let's first look at the insurance exchanges, or the individual health insurance market under the Affordable Care Act. This one picture tells you, I would suggest, just about everything you need to know about the ACA and the exchanges. First thing it tells you is that we have a problem in the take-up rate. This illustrates the percentage of people eligible for the individual health insurance market. They're not in Medicare, they're not in Medicaid, they're not in employer-based care, so they're left to the individual health insurance market. The percentage of them eligible that have so far purchased. Now this chart goes back to 2016. We haven't gotten the 2017 update yet, but in 2017 the number of people in the insurance exchanges actually fell by 500,000. So it hasn't gotten any better than this. In 2016, people earning between 100 and 150% of the federal poverty level, and that's about $12,000 for a single person at 100%. People earning between 100 and 150% of the federal poverty level, 81% of the eligible purchased an individual policy and took advantage of their subsidies to do so. That's fantastic. If you can get 75% of an eligible group to sign up, you're likely going to get a very efficient pool. That is, enough healthy people paying in to pay for the sick. But the problem is that when we look at the other income folks eligible for a subsidy, and subsidies are eligible up to 400% of the federal poverty level, as you can see, it falls like a rock. People between 300 and 400% of the federal poverty level, only 17% of the eligible have chosen to buy a health insurance plan. And this is the fundamental problem with the insurance exchanges. This is why the premiums are so high. This is why the deductibles are so high. This is why so many insurance companies have exited the market, and why we have fewer and fewer choices in the exchanges, because we just never signed up enough healthy people to pay the claims of the sick. This also tells us why Obamacare, if you will, was such a big political issue in the 2016 elections and continues to be controversial. If you have an entitlement, if you have a new entitlement and only 40% of the eligible show up, it's not working very smoothly as an entitlement. It's not going to have the political support you want to have. Overall here, about 40% of the eligible have signed up. People eligible for subsidies have signed up. And when you look at the fact that there's an individual mandate out there, people are required to buy it. If people make less than 400% of poverty, which all of these people on the chart do, they get subsidies to help them buy it. And, you know, I think we should assume that people would rather have insurance than not insurance. So when you take those things into consideration, you buy it or you get fined, you get subsidies to help you buy it. It's something you probably want to have. We only got 40% signing up. That's not an indication of a very successful program, and it's not going to be a politically sustainable program with that kind of take-up rate. So this chart, I think, tells us a lot about where we are. Now, here's a look at what it actually costs to buy a health plan in Columbus, Ohio. This is for a family of 4, mom and dad, age 40. These are the 3 cheapest plans available. They are the bronze plans with the highest deductibles, so obviously they would be the cheapest plans. Right now, it costs, for the cheapest plan available for this family, $731.38 a month for a $14,000 family deductible. I presume, this chart doesn't say it, I presume the individual deductible would be $7,000 per person, but the family max is $14,000. So the best you're going to do in 2016 is a plan that costs about $9,000 a year. Now, this is without subsidy, and in a moment I'll go through who gets a subsidy and who doesn't. Bear in mind that 40% of all households in the United States make more than 400% of the federal poverty level and do not get a subsidy. And so if you're a low-income person and you're getting big subsidies and you're getting cost-sharing subsidies for your deductibles, this is a very attractive program. And I'll go back to the prior slide. These would be the lowest income people. And as you can see there, the lowest income people tend to sign up well. But if you don't get the cost-sharing subsidies, or you don't get any subsidy at all, this is an unattractive program for obvious reasons. In fact, if we look at the 2018 rate increases for Ohio, the average rate increase in the state of Ohio is going to be 25% next year for 2018. That assumes that President Trump doesn't end the cost-sharing subsidies for low-income people. Carriers have put out really 2 levels of rate increase if he cuts them out and if he doesn't. If Trump goes ahead and keeps his promise and doesn't pay the cost-sharing subsidies for people making less than 250% of poverty, that's going to be a 33% increase. So while Obamacare has its problems, the Trump administration certainly hasn't done a lot to make things easy on people. Just with the 25% rate increase, that $731 premium is going to go to $913 or $11,000 a year. If we get the 33% rate increase, that $731 premium is going to go to $972 a month or $12,000 a year for a plan that will have about a $7,000 deductible. So you can see here why the program has been unattractive to people who either don't get any subsidies or get fewer subsidies. Now, if you look at the individual market overall, 17.6 million people were in the individual health insurance market as of March of 2017. 12.2 million in the exchanges, 5.4 million off. Year over year, 2016 to 2017, enrollment declined 12%. That is a pretty significant reduction in the number of people purchasing health insurance. This includes people who get subsidies on the exchange, and this includes people who don't get any subsidies off the exchange. It's the entire market. 57% of individual market consumers were getting a subsidy as of March of 2017, and 43% were not. And this is using the data that comes from, primarily comes from state statutory filings from the insurance companies. We know that anybody who isn't getting their insurance on the exchange does not get a subsidy. The only place you can get it is on the exchange. The off-exchange market, fell from 7.5 million to 5.3 million, a 29% decrease. Now, so what's happening here is for people who don't get a subsidy because of these ever-increasing rates, lots of them are foregoing the coverage. Now, this is as of 2017, before the 25 or 33% rate increase that the state of Ohio is going to get, for example. And we're seeing variation in rate increases around the country, but generally they're pretty high. So what you've got is really the tale of two cities here. You've got two markets under Obamacare. You've got the people who get the substantial subsidies and cost-sharing subsidies. They're pretty happy because their net out-of-pocket cost for premiums and deductibles and copays is pretty low. It's working well for the lowest income people in the exchanges. But then you get the people who either get little or no subsidy, and they're getting hammered by these increased costs, particularly the market that is now 43% of the people who don't get a subsidy. You very often hear in the press, in fact, I read a press report in one of the Cleveland papers just yesterday as I was getting ready for this, where the reporter said something I've seen dozens of reporters say, that 80% of the people get subsidies. Well, 80% of the people in the exchanges get subsidies, but a substantial portion of the market is not in the exchanges, and they don't get subsidies. So with 43% not getting subsidies, we've got, again, a tale of two markets. People who get really good subsidies and are satisfied, people who don't and are really getting hammered. Now, after 3 full years, health plans have attributed unsustainability to high medical claims. We don't have enough people signed up. Adverse selection, don't have enough people signed up. The reinsurance program that never worked exactly the way it was intended to work, immature risk pools, and under-enrollment of healthier individuals. It all gets back to not enough people signing up. 141 qualified health plans filed initial applications to participate in 2018. That's a 38% decline from last year across the country. 38% fewer health plans are participating. 46 states in 2016 had a net underwriting loss, with Florida, Alaska, Indiana, and Rhode Island the only states reporting underwriting gains. Of 179 companies filing state insurance department financial exhibits, 126 reported losses in 2016. As of July 10th, 2017, CMS reported 141 qualified health plans, again, a reduction of 38%. Now, we've obviously got some fundamental architecture problems with the way Obamacare was designed, and that's leading to all these problems. But the Trump administration is just throwing gasoline on the fire. Trump's IRS, Internal Revenue Service, has indicated that it's not going to enforce the individual mandate for taxpayers who leave questions about coverage unanswered. The latest statistics just came out, and we had 4 million people paid the penalty for not having health insurance, but that's down from 6.5 million the year prior. So for all practice, so paying your penalty for not having health insurance has virtually become an IQ test. I mean, if you're stupid enough to pay it, you pay it. So the Trump administration is not doing a very good job of enforcing that, and that obviously is going to continue to hurt things. But the biggest problem the Trump administration has is the Twitter-in-chief, who continues to tweet that he has every intention of cutting off the cost-sharing subsidies if the Congress doesn't give him a health care reform bill. And it's a long, complex explanation, but the bottom line is because of court rulings, the administration is not required to continue to pay the cost-sharing subsidies. Those are the subsidies for people who make 250% of the federal poverty level or less. They amount to about $7 billion this year in federal payments to the insurance companies, and there will be $10 billion in payments to the insurance companies next year if he cuts them off. And that's why the carriers are saying if he cuts them off, we've got to give much higher rate increases to compensate for that. Ironically, if Trump shuts off the cost-sharing subsidies, the only people he hurts are higher income people who disproportionately vote Republican. If he cuts off the cost-sharing subsidies to the insurance companies, the carriers, by law, still have to provide the subsidies to low-income people out of their own pockets until they can give the big rate increases to compensate, which would happen in 2018, and then they'd be held even. So the only people who would suffer because the cost-sharing subsidies are cut off are the people who don't get premium subsidies and therefore have to pay these additional big rate increases. If you make less than 400% of the federal poverty level, your premium is capped at a certain percentage of your income on a sliding scale. People can pay $25,000, the insurance company can charge $25,000 a month for your health insurance, but if you're at a certain income and you're capped at 3% of your income for premiums, you're not going to feel it. The federal government is going to have to pay it. It makes you immune to them. Over 400% of the federal poverty level, any additional rate increase comes out of the pocket of the consumer. Well, people making 400% of the federal poverty level and higher are the high income people, and they disproportionately vote Republican. So when the day is done, the grand irony in all of this business is that if Trump cuts the cost sharing subsidies, he's only going to hurt high income people who disproportionately voted Republican in the 2016 elections. So it's really a very foolish sort of track he's following here, but he continues to follow it. And as we all know, when he gets the bit in his mouth on something, he's not going to let it go. So we're waiting month to month to see what he's going to do about that. The Trump administration announced they would pay the August subsidies. Now we have to wait to see if they pay the September subsidies. If Trump does not follow through on his threats, it would be the first time that he admitted he was wrong. So we'll see what happens. And obviously the carriers are waiting and wondering what's going to happen. Now, the individual health insurance market, in spite of all of these problems, is beginning to return to profitability. And does that mean that the insurance markets are stable and everything's going to be fine? Well, first of all, let me remind you that if the insurance companies return to profitability next year in Ohio, they will be doing so with the cheapest plan in Columbus costing somewhere between $11,000 and $12,000. The insurance companies, ironically, can ultimately get themselves to the point where they will make money in Obamacare as we know it today. And the reason is that 60% of the market, 57% of the market is subsidized by the federal government. It doesn't matter what the premiums are to these subsidy people because they're capped in what they pay. So you have a situation like we've never had before in the individual health insurance market, where insurance companies can charge astronomical premiums. The federal government simply compensates by paying higher subsidies. And the people under 400% of federal poverty level are completely insulated from these increases. Now, the people making more than 400% of the federal poverty level, 43% of the market right now, are not subsidized. And so they will tend to drop their coverage if they're healthy because the costs go up so high. And that's what we saw between 2016 and 2017, where nationally 29% of the individual market, unsubsidized market, evaporated. But the market under 400% of poverty will hang in there because they're still going to get a good deal because of the subsidies they're given. So again, we've got sort of a tale of two cities here. When it comes to the under 400% of federal poverty level, the best strategy for insurance companies in this crazy atmosphere is just to jack up the rates, get them as high as they need to get them until they make money. So you're going to hear and see more and more reports over the next year or so indicating that insurance profitability is improving and the markets are quote unquote stable because now carriers are making money and they'll probably stay in the market. Yes, that's true, but at ever higher and escalating prices that the market that doesn't get a subsidy are just going to take right on the chin. So people talk about death spirals. Well, you have two markets here. The subsidized market can't death spiral because people are insulated from the premium increases. But we likely already have a death spiral going on in the unsubsidized market. When you have that market decrease by 29% in 1 year, you got a death spiral. So we're probably going to see worsening conditions outside the subsidized market. But inside the subsidized market, the carriers are going to charge whatever they have to charge in order to get their bottom lines to break even, and that's what's going on. In fact, what we're seeing is the individual market starting to stabilize for insurance companies. Here we can see the medical loss ratio. It peaked in the first quarter of 2015. It's come down in the first quarter of 2017, and I expect you'll see more and more insurance companies in more and more states reporting profits because of this. But they'll be charging in Columbus, Ohio, between $11,000 and $12,000 for the cheapest family plan. Now, let's talk about the Medicaid expansion. 32 states have expanded, 19 haven't. Obviously, it's been very controversial since the Supreme Court ruling that gave the states the option. I don't have to tell you in Ohio it's been controversial. John Kasich got out front and said, we're going to do it. He's had some trouble with the state legislature over that. It remains controversial in Ohio, and it remains controversial across the country. And if you look at this map, largely it looks like the electoral map in the last couple of elections, where the largely red states have not expanded and the blues have. There are exceptions to that, obviously, like Ohio and Arizona, but that's generally the case. Medicaid costs are an issue, and that's why I showed you those overview slides early on. I personally believe that all of the governors should take the Medicaid expansion, because what else are you going to do with these people? You can't expect somebody making $12,000 a year to buy a health insurance policy. If I look at 2013 prices for health insurance policies, they're not going to be affordable for somebody who makes $12,000 a year. So we've got to have a special solution to the problem. So I'm not here to tell you that the states shouldn't have taken the expansion. I have written op-eds in support of John Kasich's expanding in Ohio, for example, give you full disclosure. But at the same time, this is a major issue. And in a number of states, we've seen the enrollment come in much higher than expected. Good news, bad news. We're covering more people than we expected. More people are covered. That's the good news. The bad news is it does have a big impact on state budgets. Even with the Obamacare expansion subsidies, ultimately the states are paying more and more. We've seen in Ohio in particular, we've seen what we call a lot of woodwork, people coming out of the woodwork expansion, because when people went out and did the public relations for the expansion, hundreds of thousands of people who were eligible before learned that for the first time perhaps that they were eligible under the old Medicaid program and signed up. So we got an expansion both because of the Obamacare expansion and because people learned that even under the old program they were eligible. So we've got many more people than we thought, and the costs are much higher than we expected them to be. From 2013 to 2016, Medicaid enrollment grew from 56 million to 74 million, a 32% increase in 3 years, primarily because of the Obamacare expansion. Now, many Republicans will say, you know, Medicaid was supposed to be a safety net program. It wasn't supposed to be the biggest insurance plan in the United States. And they have a valid point there. At 74 million, it's the single biggest insurance plan now in the United States. 49 million are in managed care plans. More and more of this population is being moved to more aggressive management run by subcontractors, basically the insurance industry. 77% of the growth, not surprisingly, took place in expansion states. The per-person cost of expansion was higher than we anticipated. You know, why? You don't know. It's all part of the issues. But at any rate, we've seen costs higher than we originally anticipated. So let's look at the Republican efforts to repeal and replace Obamacare with that backdrop. The Affordable Care Act Republicans tried to deal with it in two places, the House of Representatives and the Senate. Their bills were somewhat different. Overall, in terms of the philosophical structure, they were very close to the same, but there were a lot of details that were different. The Affordable Care Act, Obamacare, most benefited lower-income people. The Medicaid expansion, the best premium subsidies and out-of-pocket assistance for those below 250% of the federal poverty level. Obamacare has worked well from a consumer perspective if you make less than 250% of the poverty level, either by being in Medicaid or having substantial subsidies in the private market. The House Republican plan would flip that over. It would most benefit working and middle-class people with more generous premium subsidies at the expense of those under 250% of the poverty level. Older people and the eventual repeal of Medicaid expansion. So they really flipped on their head the Obamacare priorities. The House Republicans would have also cut taxes by $800 billion for those making over $200,000 a year, the drug industry, the medical device industry, insurers, and others. So it was a very different set of priorities. Cut taxes on corporations and high-income people, and cut benefits for the lowest income people. I mean, Obamacare has been criticized as being an enormous transfer of wealth from the middle class to lower income people. The House Republican plan has been criticized as reversing that transfer of wealth back up to higher income people. And that's why it was very, very controversial. Here's a chart from the CBO's analysis of the Senate bill, which was a little bit different. At 30,000 feet, looking down at both, very similar, but they had some detailed differences. The Senate bill was an attempt to improve upon the House bill that Donald Trump called mean one day. I mean, so there was a sense that the Republicans tried to go too far with the House bill, and they wanted to back up on some of those things in the Senate bill, but still substantial transfers. Medicaid was cut $842 billion over 10 years. Now, much of that is in the out years where the Republicans tried to slow the growth rate. And so be careful here in looking at that number and saying, oh, those nasty Republicans. Remember what the slide I showed you at the beginning, where if we don't start to figure out how to get these entitlements under control, we're in big trouble. So what Republicans were trying to do is to give the states more autonomy to more aggressively manage their programs. Right now, Medicaid is an entitlement to the states. In that, whatever state costs go up, the federal government has to match a certain percentage of the state's increase. If the state costs go up $100 million in a given year, they suck, say, $50 million out of the federal treasury through the matches. So there isn't the greatest incentive for the states to control costs. Yes, they have a substantial portion of the costs themselves. Under the expansion, no more than 10% of those costs. While there's pressure on state budgets, they can continually call on the federal treasury to just write the checks for whatever. So the Republicans said, we're going to put some caps on that. You're going to get capped on what you get, and you're going to have to manage it better. And while the Republicans cut the program such that many people would lose their Medicaid expansion and instead be given insurance subsidies, much of the cuts in Medicaid are these out-year cuts where the Republicans were trying to bring Medicaid costs in balance. And that is not, in my mind, a black and white issue. Republicans are bad guys, good guys, whatever. When you look at where we're headed over the next few decades in terms of entitlement costs, this is a direction we have to at least look at. Many Democrats were highly critical of this. Bernie Sanders and Elizabeth Warren, for example, said these are terrible cuts, we really need to go to single payer. And many of you in the audience this morning may be single payer advocates. And I want to challenge you on something in that regard. What is single payer? Single payer is global budgets. Healthcare systems in Canada and Great Britain and France and Germany have worked well over the years because they have put their systems on global budgets, hard caps and spending. And as a result, the healthcare system has had to figure out how to cope with those caps and manage them. What the Republicans were effectively proposing here were global budgets. I think it's ironic that the most liberal of the Democrats are effectively proposing global budgets with single payer. At the same time, Republicans are. Now, were the Republican global budgets too draconian? You know, it would be interesting to price out Bernie Sanders' single payer plan where he says he's going to save enough money to be able to give everybody cheaper rates and no deductible plans. He's going to have to carve out a lot of money from the provider community to be able to do that. In fact, if you look at Medicare and Medicaid payments versus private sector insurance company payments right now, Medicare and Medicaid payments under the current regime for hospitals are 50% as much as in the private sector. If you look at the prices paid for Medicare and Medicaid versus the prices paid for self-insured employer plans, for example, the prices the hospital gets are 50% of what they get from the insurance companies. So if you do Medicare for all, you're going to be talking about some draconian cuts in the out years that are sizable. So when it's easy, I think, to criticize the Republicans for quote-unquote draconian cuts, we really have to assess what single-payer and global budgets would do at the same time. And so I don't think this is as black and white an issue as some people may have made it out to be. And you're listening to somebody here who has supported the Medicaid expansion in Ohio, for example. But they did cut a lot. Did they cut more than Democrats would cut? You know, now we get down to the negotiations about how much should you cut, but they cut a lot. They also cut tax credits for the insurance exchanges, $454 billion. And then they cut taxes and other fees to the tune of $613 billion. It is clear also that in order for the Republicans to do their tax cuts in the tax cut bill that was to follow, they were able to pay for many of those tax cuts because they took money out of Medicaid and away from the tax credits. I mean, that is black and white. That's clearly the case. So as you can see, this is a very controversial set of changes. Not all of them perhaps as draconian as on the surface as they might be, but clearly some really big changes here. So where do we go from now? Of course, what happened is it all crashed and burned. They didn't get the votes. Moderate Republicans would not come on side. Moderate Republicans, particularly concerned about the Medicaid expansion, would not come on side. Senator McCain cast the deciding vote, in great part because Governor Ducey, the Republican governor of Arizona, was concerned about the way it would impact the Arizona Medicaid expansion. Your own Governor Kasich was very much opposed to the Republican bills. And I have to tell you, and I've been critical of Obamacare through the years, I have to tell you, I think the Republicans were lucky this didn't pass, because my analysis of both the Senate and House Republican bills is they would make the insurance system worse than what it is now. One of the biggest reasons they'd make the insurance system worse is, remember, in the early part of this presentation, I told you the biggest problem is we don't have enough healthy people signing up to pay the claims of the sick. What the Republicans would have done is taken millions of people off of Medicaid, dumped them into the individual health insurance market, and given everybody worse subsidies than we have today. Well, if you dump millions more people in and you make the subsidies worse, are you going to have a better percentage of people signing up or a worse percentage of people signing up? I think clearly you're going to have a worse percentage of people signing up. And so the bottom line is you'd probably have a worse risk pool under the Republican plans than you have even under Obamacare. So I think that the Republicans probably lucked out here because while they could have had this celebration party in the Rose Garden after they passed repeal and replace, they'd have had to live with it for a few years, and I don't think the results would have been too good. So where do we go from here? And after 5 months of the Republicans trying to do repeal and replace, a bipartisan compromise, people are talking about that, but there's currently no bipartisan overlap between the conservative Republicans whose holy grail is to roll back Medicaid and for Democrats whose holy grail is to protect Medicaid. I mean, that we look at the insurance exchanges get most of the press and the premiums and the deductibles and all the rest of it, but the fundamental issue here, the reason John McCain voted no, is because of the Medicaid changes. And that's where really most of the conflict is. Now, Medicaid is currently stable. You saw the charts I showed you at the beginning of the presentation. It's not stable over the next 20 years, obviously. This is a problem that's got to be solved. But but it will go on over the next few years, bopping along just as it has now, covering lots of people if no changes are made. The more immediate issue is the stability of the very high subsidized and the very high unsubsidized prices and deductibles in the insurance exchanges. For low-income people, the exchanges are stable. The premiums can go up to $25,000 a month because for people on subsidy, but because they're capped in what they pay out of pocket for their premiums, they'll never see it. They're immune to it. The taxpayer will just subsidize it. The people who are getting hammered are the people who get little or no subsidies, and that's where we have an instability problem. And when people talk about how Obamacare is stable, my experience is when I read these articles or I hear these comments, they're talking about insurance company profitability. Well, this isn't about insurance company profitability. Yes, insurance companies are going to be stable because they jacked up the rates to high heaven and suddenly got themselves to profitability. They're going to be charging $11,000 or $12,000 next year for the cheapest plan in Columbus for the family. Yeah, they're stable, but is it stable for the consumer? Is the program stable? Is the program politically stable? And I think that that's foolishness. It's not even close. Democrat ideas to fix Obamacare right now include a list of a number of things. Focus on the individual market, no Medicaid changes, a permanent $15 billion a year health insurance company reinsurance fund. Again, that if you put billions of dollars into giving insurance companies subsidies to cover these big claims, you would stabilize the companies and you would stabilize their premiums, but you wouldn't reduce their premiums. You just make sure they wouldn't go up 25% next year. But they're already going to be at $11,000 or $12,000 in Columbus for a family plan. So you would stabilize this thing at that level. That's not a solution. That's just subsidies to make sure it doesn't get any worse, and it's nowhere near acceptable. They would make the low-income subsidies permanent. They would enforce the individual mandate in an effort to promote open enrollments. Many ACA advocates say, well, maybe the fine for the mandate isn't high enough. You know, the problem is we got to get more people in. Let's enforce the mandate. Let's fine people. Well, folks, let's think about that for a second. The cost in Columbus, Ohio is going to be $11,000 or $12,000 for a family of four. And you know, if we could get more of these families to buy the product, we would probably get a better medical loss ratio. Is the solution to fine people more because they look you in the eye and they tell you they can't afford $11,000 for a health insurance plan with a $7,000 deductible? That's the reality. And the solution is to fine them because they won't buy it? Let me suggest the solution is to fix the problem, not fine people. Other Democratic ideas are align the open enrollment dates with tax filing season, allow Medicare buy-in for people over the age of 55, get the older people out of the pool and get them into Medicare. That would help, but it's cost shifting. We just take these people and we put the burden someplace else. In counties with no exchange carrier, apparently you may have the only one in the country in Ohio, give people access to the federal employee program. The public option, put a public health insurance plan like Medicare in competition in the exchanges with the carriers, which of course is the thing that many Democrats pushed when Obamacare was first passed and they didn't have the votes to do it, or go all the way to single payer. So there's been a large range of ideas. Now, John Kasich had an op-ed in the New York Times. I'm not showing you this because I'm talking to people in Ohio today. If I were talking to people in California, I'd show it, because I think he made some excellent points. And so, I compliment your governor. I think he made some excellent points, and I think they're worth taking a look at. He said the Senate Republican plan was rejected by governors in both parties because of unsustainable reductions in Medicaid. Particularly problematic was the bill's failure to adequately meet addiction and mental health needs. The Senate plan also failed to repair Obamacare's damage to the health insurance markets. Insufficient tax credits would make coverage affordable for sufficient tax credits, I think that should read, would make coverage more affordable. Before rolling back Medicaid, first fix the exchanges so we have somewhere stable for them to go. Provide adequate consumer tax credits, which would keep health plans in the individual market. Health insurers should be required to continue following reasonable guardrails, like ensuring minimum coverage that is generally useful and covers pre-existing conditions. On Medicaid, states are willing to assume greater financial risk by transitioning to a block grant or per capita cap, but will also need new flexibility. So he's saying, okay, we've got to reform Medicaid, but we'll take greater risk, but we need it more of a transition. So fix and stabilize the markets first, make them more efficient. Yes, we're going to have to go to more budgets on Medicaid because of the longer term issues, but let's transition more smoothly. So those are the kinds of sort of middle of the road ideas. I think this fairly represents middle of the road ideas in terms of where we're going. States cannot expect the federal government to continue paying 90% of Medicaid expansion costs given our nation's historic debt. They must accept a gradual return to traditional cost-sharing levels. We can never truly fix the rising cost of healthcare services unless we start paying for value rather than volume. So again, I think a more moderate between the two sides approach gives us an indication of what that might look like. So what now? Well, September is going to be an extraordinary month on Capitol Hill, I'll tell you that. The federal debt ceiling has to be raised by about September 29, or we default on our debt. And that's going to be a big issue because lots of Republicans don't want to extend the debt ceiling without federal budget cuts, which Democrats don't want. So this is by no means assured. The government will run out of money on October 1st because they never did do a 2018 budget. We haven't got the go-forward 2018 budget done. And so we're going to have to figure out how to do these continuing resolutions. And there are so many controversial issues caught up in this debate that might get loaded on to a budget extension. And we've got to be concerned about that. And the Children's Health Insurance Plan, which is an offshoot of Medicaid, passed by Hatch, written by Hatch, Senator Hatch of Utah, and Senator Kennedy of Massachusetts many years ago. Generally bipartisan support, covers 8.9 million kids. It runs out of money September 30th, and it's got to be extended. So those are the must-dos. And then you've got health care reform sitting there that they didn't get done. Then you've got the tax reform that they claim they need to get done by the end of the year, infrastructure, immigration, all these issues. The whole Republican agenda is log-jammed behind these sort of crisis issues that have to be taken care of by the end of the month. And the Congress is in session for 14 business days in September when they get back. So we've got a whole series of issues. And the insurance industry will be pressing hard to get rid of the health insurance tax, which all self-insured employers, all insured employers are paying. It's a substantial load on top of all insurance premiums. The medical device tax, which is a $20 billion a year tax, is enormous pressure from that special interest to get rid of it. So we've got all of these people and all these things in the mix. Democrats and Republicans are talking about ways to shore up the exchanges. There'll be hearings in the Senate Help Committee run by Chairman Lamar Alexander of Tennessee and Patty Murray of Washington, the ranking Democratic member. They're going to try to figure out ways to temporarily shore things up. There's general agreement in the Congress to continue the cost-sharing subsidies. But for that to happen, Republicans are going to want some things. And they're going to want at least more flexibility at the state level so that insurance companies can craft more flexible plans and try to get more people into the market. But many Democrats are afraid of that because it means stepping back on many of the consumer protections and benefit mandates that are in Obamacare. So that would be very controversial. So even a temporary shore-up bill is going to be problematic. Hearings will start right after Labor Day in that committee, and if progress can be made, that's where it will be made. And that's the thing to keep an eye on. Keep an eye on the Senate Health, Education, Labor, and Pensions Committee hearings in Washington. That's ground zero for shoring up Obamacare going forward and the possibility of any bipartisan compromise. And that's where that will be dealt with. But there's no sign of any solution that would fundamentally alter the course of health care costs or a fundamental across-the-board insurance reform bill. Republicans, Senator Orrin Hatch, the Republican chairman of the Senate Finance Committee, said the other day, he said, "We shot our wad on health care. I'm sick of it. Time to move on to tax reform." Well, Senator Hatch may be sick of it, but the rest of us are sick of the mess you left us, so we've got to have some progress here. So that's where we are today going into September. And I'd be happy to answer any questions in the time we have remaining. Is the moderator on? I'm not hearing the moderator on this side.
Well, I'm sorry about that. I apologize. Okay, so get started with the first question. As a compromise to the individual mandate, is there any value in mandating a catastrophic plan for all Americans and then giving the option for buying up to the metal plan level without a mandate?
Well, yes. The question is, what does the catastrophic plan look like? You know, if one of the fundamental problems with a catastrophic plan is if you give somebody who's making $15,000 a year, which would be, I don't know, 135% or so of the federal poverty level, a plan with a $10,000 deductible. Let's say you give him that catastrophic plan for free, based upon the subsidies. The premiums are so cheap, he gets that thing for free. All right, now he's got a catastrophic plan, but it's got a $5,000 deductible, and he makes $15,000 a year. The good news is we gave that person a free health insurance plan. Let's all applaud that. But we gave them a health insurance plan they couldn't really use. So it really, I think, you know, it skirts around the edge, which is we have to have plans, health plans that people value. The fact that we got only 40% of the subsidy eligible signing up is the biggest problem we have with affordable health insurance here. The insurance industry, and those of you who run employer plans know that we typically like to see 75% of an eligible group sign up in order that we have a balanced pool. We got enough healthy people paying the claims of the sick. If instead of having 40% of the Obamacare exchange business signing up, we had 75% signing up, and I've discussed this with a number of actuaries around the country and a number of different companies, and everybody generally agrees if we had the sign-ups that we need, we could probably drop the rates by 40%. You know, the Obamacare insurance prices are high because there's some benefit mandates. They're high because we have guarantee issue now compared to what we had in 2013. But by far the single biggest reason they're high is because we only got 40% of the people sign up. So the real issue here is how do we bring these prices down? And you can do that in a number of ways. You can subsidize the insurance companies, which some people are talking about. But the subsidies they're talking about wouldn't bring the prices down. They probably just prohibit them going up even further, and they're already at an astronomical level. I think you've got to fundamentally go back into the architecture of Obamacare, and you've got to restructure the way it was put together in the insurance exchanges. And in the time we have today, it's hard for me to get into those details. But if you go into my blog, last night, I posted my suggestions for the Senate Health Committee in what they could do to make the market more robust. And so if you're interested in my suggestions and how that's done, go to my blog, just put my last name in Google with blog next to it, and you'll get right to it.
Okay, the next question someone had is related to the idea you brought up of the per capita caps being similar to the global budgets of single payer. And I guess this person has more of a statement, and I'll have you react to it. They say that the per capita caps differ from global budgets of single payer in two ways. One is that other single payer countries negotiate drug prices while the U.S. Medicare program does not. And they also say that they're not pulling billions of dollars out of their health budgets as per capita caps would pull out of Medicaid. So I don't know if you could react to kind of if you see.
Well, I don't disagree with any of those things. I don't disagree with any of those things.
So could you explain a little bit?
That's just more of an explanation of what global budgets look like. But either way, you know, to make a global budget work, you got to do certain things. Now, one of the things you could do to make a global budget work better would be to control drug prices. You could go to the drug companies and say, you know, you're not charging $100,000 for a Hep C drug, for example. I mean, that's a separate debate. So, yeah, I don't disagree with those comments as to what makes these other countries different, but understand we just glossed over two mega policy changes from where we are. And by the way, you could do those things. And by the way, you could do those things without single payer. You could regulate drug prices right now, not go to single payer. Single payer is not the issue. It's what are you going to do with drug prices?
Okay, and we're running short on time, but one more question. Could you talk a little bit about what you know or have heard about the Kasich-Hickenlooper proposal?
Yes, thank you for bringing that up. We've heard very little, of course, but Kasich and your governor and the governor of Colorado have been working on a bipartisan proposal to send to the Senate Health Committee. They've said that they're close to having it done and that we'll see it the next day or two. And we're all eagerly awaiting what that looks like. That, you know, Hickenlooper's a Democratic governor, Kasich's a Republican, of course. They're both very smart when it comes to healthcare policy, and they could have some very interesting suggestions, and we don't know what those look like yet.
All right, great. Well, thank you very much, Bob, for your time and your insight. Sorry about that. Thank you very much, Bob, for your time and your insight. Before you leave, we'd like to ask you all to take a second and let us know how you'd rate our webinar. This feedback is really helpful to us as we plan future events. And remember, as we said at the beginning of the webinar, the slides used during today's presentation, as well as a password-protected recording of the seminar, will soon be available on our website, hpio.net. The final seminar in this series is scheduled or being scheduled for later in this year, likely in September, right, Haley? Or November, I'm sorry, November, Haley. Just let me know. So look for an announcement on that in the coming months. Thanks again, Bob. We'll look forward to keeping in contact with you, reading your blogs, seeing you appear on national news outlets as we all stay up to date on the most recent action or inaction in Washington, D.C. Hope you all have a great day.
Thank you. Bye.